after we let more people join in. We're also waiting for Dr. Anike, the National Coordinator of the National TB Program. So hopefully he should join within the next 5 minutes or so. So we'll start shortly. Thank you for joining.
It's now also being live streamed on YouTube.
Okay. Hello, Aji. Hello. Okay. Hello. Okay. Yeah.
Hello,
All right.
Dr. Anyike.
Good afternoon, everyone. Thank you so much for joining us today for this webinar. This webinar is going to be focusing on the work that TB program has started to do with PPMV over the last couple of years, some of the successes we've seen, some of the challenges that we're experiencing, and it's just an opportunity to discuss it further, share lessons so that implementers and anyone who has done any great work in this space can share it with others and we can learn from it. We can also hear about our common challenges and explore opportunities and solutions for the future. So that is basically it in a nutshell. I'll start by introducing our national coordinator, Dr. Chukwuma Anyike, who will welcome us all before we continue. Thank you very much. Sir, I think you're muted. Okay, you're muted now.
Yes, good afternoon, everyone.
Good afternoon, sir.
I'm sure you can hear me now.
Yes, sir,
we
we can hear you.
So let me humbly welcome everyone to this very important meeting. And we pray we'll continue to have a more regular meetings like this, because the national program is putting every measures to maintain our momentum of increasing case notification for tuberculosis in Nigeria. And it's evident that we won't be able to achieve our milestone in terms of ending tuberculosis in Nigeria if we do not deliberately engage the private sector and the private health facilities. Just as it's on record that 60% of Nigerians first go to the private health facilities for any form of ailment. And so the national program bought into that idea and has been running with it. The results we have are testament to what we are saying. At the end of the first quarter of this year, we realized that the PPM has contributed 27% of our case notification. And so we want to scale it up, involving every component of the private sector, especially the PPMVs, because we have looked through our record. A very veritable and verified group of people that we must work with. What we need to do is to ensure that we build their capacity and also strategize more in terms of keeping the data so that we do not lose any data, because data is what we can use to confirm that we actually worked. So this webinar is, it's coming at the right time so that we'll be able to document and also, X-ray what we have been doing towards scaling up PPM in Nigeria. We want to also use this opportunity to showcase what we are doing at the national program in terms of the new innovation we've just concluded last month, of occasionally going on outreach, especially when it concerns the children. We felt that we must be able to, improve on our care education on children. And so last month, that strategy has worked. I want to place it now on this platform. That strategy worked, and we think is something we need to sustain. And we ought to be able to, even at the private sector angle, to ensure that we actively and deliberately put that as one of our strategies. So you are going to listen to well-tested, experts with great skills that are going to tell us, what we can do to ensure that we keep the ball rolling in terms of care notification of tuberculosis in Nigeria. So let me, on behalf of the National TB Program, welcome all of us to this very important webinar. And I urge every person to be vigilant and attentive so that at the end, we'll have the cause to have put in a lot of energy in trying to rub our minds on our national strategy of actively and deliberately scaling up our PPM interventions. So thank you very much. And I'll hand over to Azze to continue with the program. Thank you and have a nice weekend.
Thank you very much, sir, for that wonderful
Thank you, sir.
address. So can you confirm that you can see my screen?
Yes, we can
All
see
right.
it.
Okay, thank you. So I'm going to be doing, my screen is not moving, okay, yeah. So I'm going to be providing a very brief introduction to the TBPPM Learning Network. It's a platform, it's an online platform that was launched in October 2019. And the whole idea of the platform is to create an opportunity for learning around PPM. As PPM continues to grow on a global level and in different countries, it's important that we spend time reflecting on the learnings, ensuring that we are consolidating what it is that we're learning, we're sharing what it is that we're learning, and that we are having conversations. Because I find that when we are so busy implementing, which is the focus of what we do and not a bad idea at all, we tend to forget about the learning parts. And the disadvantage of that is that sometimes we end up not being able to appreciate what other people are doing so that we can apply that as well. And it also gives us, it also doesn't allow us to even sometimes just lean back and see, okay, what have we learned? What have we grown in? And so on and so forth. And how can we use that to improve the program? So the idea of the platform is to create a deliberate opportunity to continue to do that, to create a platform that lets you do that. So we have an online site, which has almost 3,000 members globally, who are also working in the PPM space in different countries. And it's basically just an opportunity for that. And even in country, because Nigeria is doing so much when it comes to PPM, we have so many success stories that the world wants to hear about. We have a Nigeria chapter of the PPM Learning Network, and this webinar is one of the things that we hope to be doing more of. We want to have as in the PPM space in Nigeria and share our experiences, share our challenges, and tackle these things together as a group. So on my screen, you will see the link. So I know most of you here are already members of the online platform, but if you aren't, please sign up. This is the link. We're also going to put the link in the chats. So if you're not a member, please join. There are lots of resources there, and there are lots of opportunities for networking and so many other opportunities. If you want to know more on how you can leverage the network for the work that you do, or you want to showcase your story, or you want to learn what other people are doing, please feel free to reach out to me to ask further questions. As we go ahead in this webinar, please feel free to, first of all, introduce yourself. We'll not be able to go around and introduce one by one, but if you can introduce yourself in the chats, put your name, put your designation, your organization. We would really like to know you and all the people who joined the call. Also, please feel free to ask questions and make comments as the presentations are going. So thank you so much all for joining. I will hand over now to Stella Maku, who is the PPM focal person for the National TB Program, and she'll take us through what to expect next. Thank you.
All right, thank you very much, Azi. You are all welcome to this webinar. Thank you all for finding out time to be here. This will afford us opportunity to learn from one another. So now, like Azi said, we have to do some kind of self-introduction. So what will happen is you just put your name and your maybe your designation and your organization. So we can, yes, we have Stephen John here too. We have yeah. Okay, and wherever you are coming from or you're listening from, you are all welcome to this webinar. So the webinar topic, opportunities and challenges for TB service delivery via patent medicine vendor in Nigeria. It was selected because PPMV represents an increasingly important way to find TB cases, and most stakeholders agreed that it is important to discuss it. Share your insights, then knowledge and questions. Actually, a survey was conducted and it came up to the fact that this topic is very important and needs to be discussed. So having said this, I would like to introduce the speakers. First on my list is Dr. Adetiba from IHVN, who will be taking us on the overview of PPMV activity in TB service delivery. So the second on the list is Emmanuel Olashore, who is going to share with us lessons learned from his personal experiences in the field. Then Fola Shade Ojeleke from Lagos will also share her personal experiences. Their full bios can be found on the registration page if you want to know more. So we'll open the floor for discussions, questions, comments, and so on. So also you feel free to ask questions and comments in the chat. We have a chat box there that you can always put in your comments. I will at this juncture invite Dr. Adetiba. Dr. Adetiba, are you there? You have 15 minutes, sir. Over.
Dr. Adetiba, I'm trying to put up your presentation. Or do you want to share it yourself? Or should I share it for you?
Aji, you can share it, please.
All right. Okay. So give me a second. All right, we're good to go.
Okay, thank you very much, Aji. Thank you, everyone. I'm Dr. Temitope Adetiba from the Institute of Human Virology, Nigeria. So I'll be speaking this afternoon on the overview and challenges of PPMV engagement in TB service delivery in Nigeria. Next slide. Okay, so this is my outline. I would not need to go through this because of time. Next slide. Okay, so just by way of beginning, The Institute of Human Virology Nigeria is a non-governmental organization that was founded in 2004. And the mission of IHVN is to be a center of excellence in providing health services, capacity building, research, and ensuring equitable access to quality healthcare services through innovative and evidence-based strategies. And you can see our core values here at IHVN, which overarches all the activities and the grants that we implement. IHVN implements grants ranging from HIV, cancer, malaria, and TB. Next slide. For this presentation, I'll be speaking about our work in the private sector for TB. So the Global Fund has funded a TB public-private mix grant, that's the PPM grant, which IHVN began to implement in 2019. But the goal of the current grant is to increase the private sector contribution to national TB notification from 14% in 2019 to 35% at the end of 2023. You will have heard the national coordinator of the National TB Program mention that we have seen significant increase in private sector contribution. And at the end of the first quarter of this year, we had as much as 27% of all the cases, and that's about 80,000 cases in the country. 27% of that was from the private sector. The grant also has a goal to increase access to molecular diagnostic testing in Nigeria from 58% in 2019 to 75% at the end of 2023. In the course of my presentation, you will see that we are very close to achieving these goals. We're currently working in 21 states, which you will find here. So not the entire country hasn't yet been saturated for private provider engagement, but we're working in 21 states at the moment under the Global Fund grant. And so most of my discussions will come from our experience in working in these 21 states in the last couple of years. Next slide. So this just to show the states where we are working on the map. You can see some states that are still in white. It just means there are still a large part of the country that is yet to be covered. Next slide. So these are the main activities that we are implementing under the Global Fund Public-Private Mix Grants. On the top, you see deployment of MATS app, which is the mobile application for TB screening and notification. We have the intensified case finding activities through the hub and spoke model. I'll be speaking to this shortly. We are also engaging different stakeholders at all levels for private sector engagement in TB. And very importantly, we are using incentives, performance-based financial incentives and enablers for case detection in the private sector. We also know that it's important to have a strong data management system. So that's another area of our focus. And then we're making available different tools for TB diagnostics, ranging from the chest X-ray, molecular diagnostics, and putting all this together to ensure that there is access to those tools across the country. Next slide. So as I mentioned previously, this is the hub and spoke model that we operate. At the ferry, you will see what we call the spokes. So the spokes consist of patent medicine vendors, the subject of our conversation today. We also have other structures at that spoke level, community pharmacists. We have the traditional birth attendants and healers. And then we have some public health facilities. All of these structures at the peripheral, the spokes, feed into the hub facilities. So these hub facilities are the private hospitals and clinics and private diagnostic hubs. And also we have the faith-based hospitals and clinics. And so it is through this model that we implement the PPM grant in the states where we work. And we have sort of ad hoc staff who are responsible for the linkages in this model. We call them linkage coordinators. So they are the ones who engage with the spokes and the hubs, patient referrals, linkages, documentation, all falls within the purview of these linkage coordinators. Next slide. So what model have we adopted in engaging the patent medicine vendors for TB program? So the first step we take in engaging them is to carry out provider mapping. So in all the states where we work, we find out where can we find these PPMVs. We map them by local governments. And once we have mapped where they are, doing this in collaboration with the state TB program, the umbrella bodies of these PMVs in their states, we are able to go further to conduct an assessment. So we have standard checklists to assess these PPMVs for their suitability to provide TB services. Those who meet the criteria from the checklist, we go further to engage them. So after they are engaged, we need to build their capacity to provide TB services. So we train them, we give them the necessary information that they need to effectively deliver TB services. The next step is that we provide the tools they require to do the job. So these tools include the paper tools for documentation, the commodities and consumables to provide TB services. So we are talking about the sputum cups. We are looking at the PPEs they need to take samples from their patients. And we also provide job aids to enable them perform their duties effectively. We also go ahead to provide continuous mentoring and supervision. We have learned that this group of providers in our environment are usually not highly technical people. So they require constant mentoring, supervision to continue to be effective in their roles. And lastly, on this ladder, you will see that the performance-based incentives and enablers, because these providers are set up for profit, we need to incentivize them to perform their roles effectively. And we have seen that this really works, which I will demonstrate in the coming slides. Next slide. So what were the results from 2022, the annual performance? You can see from here in the 21 states, we had 33% of all the cases from those states coming from the private sector. But if you look down at the second point, this represents 56,810 TB cases notified by the private providers. And at the third point, you will notice that the PMVs alone contributed almost 30,000 of the 56,000 cases we got from the private sector. So it just clearly tells us that this group of providers are very critical in TB service delivery in Nigeria. Next slide. So here I'm trying to bring out and one of the points that we might end up having discussions around in this webinar. I'm looking at the number of facilities and the spokes, that's mainly the PMVs that we engaged in the Global Fund PPM project. You can see for the PMVs, we have over 12,793 of them that were engaged on this project. But if you look at how many of them notified at least, what proportion notified at least one TB case, you see just about 16%. So what this tells you is that there is still a lot more to do with the engagement of these providers. And if we can get at least 60 to 70% of them notifying or reporting at least one case, you would see that our numbers would almost triple. And so this is an area that we have been looking at with our team, and we are coming up with solutions to address this, which we would also discuss in the course of this webinar. Next slide. So what do we exactly require from the PMVs? So that's the next question. So the private TB service provider mix is what you see here. What do they do? Each of the groups of providers that we have engaged. I'll just go straight to the PMVs. So you will notice that the PMVs are not really tasked with doing so much along the TB care cascade. They mainly identify clients who are symptomatic for TB, and they refer those clients. The only other roles that we also require from them is to maybe stand as treatment supporters when the patients or when the clients eventually are diagnosed with TB. So they support that treatment. They do not provide treatment. They only support the clients to adhere to their treatment and get cured. So this is the task mix for the PMVs in this arrangement. But we are coming to see, after some years of experience working with this group, that there is a tiered accreditation structure. That's to say there are some PMVs who have training as healthcare workers. Some are even healthcare workers who open these patent medicine stores as something they do on the side. So these could be nurses. Some of them are even doctors who run these PMVs. So what we have identified is that we can work more with this group of providers who have skill, trained healthcare workers to go further than just identifying and referring clients. They can also provide treatment in some instances. Next slide. So this just shows you the cascade for our TB program in the 21 states. In 2022, like I stated, you can see from the first part of the cascade that we were able to attend to more than 4 million people in the course of the year. Of these 4 million, more than 563,000 of them had symptoms of TB, so they are presumptive TB. And of that number, over 56,000 had active TB and were placed on treatment. And like I said in the previous slide, we see that the PMVs contributed almost 30,000 to this number. Next slide. So this just shows you the trend of how private sector engagement in the 21 states in the last 5 years has really contributed to TB case finding in the country. From 9,000 cases in 2018, we are talking about 56,000 cases in 2022. That's a very significant leap. Next slide. So we are looking closely at what the PMVs are contributing. And like I stated earlier, from the presumptives identified to the cases notified at the end of that year, you can see that the PMVs are the major drivers of our case finding in the 21 states we are working. And that just shows us that if we focus on this group of providers, we would get significant results from them as we progress in TB control efforts in Nigeria. Next slide. So the next slide is again just taking a deeper look at our data. We didn't just want to look at 21 states as an aggregate. We wanted to look at each state individually and see what exactly the PMVs are doing. What is the data telling us? What we can see here on the top chart here is that the PMVs are contributing significantly to the presumptive TB cases identified across the 21 states. That's what it shows us in the top slide. And as you go to the bottom, if you look across the 21 states, you will see that many of the states, also the PMVs, are responsible for a lot of their case finding. What we also noticed from here is that we are analyzing the presumptive to case ratio. The initial thinking was that because PMVs are not highly skilled healthcare workers, they would identify many people who are called presumptives, but at the end of the day, only few will turn out positive. But that's not the case. We are seeing that the PMVs are measuring as well as the healthcare facilities in the presumptive to case ratio. So we are having a ratio of about 9:1 from PMVs, which is also very remarkable considering what we had taught earlier. So the data is telling us that this group of providers are really doing way above our expectations. Next slide. So we took a look at the top 6 performing states, that's for the PMVs, where the PMVs are doing more than 50% of the case notification coming from private sector in those states. So we took those top 6 states. What we could see from those states is that we have over 3,000 PMVs engaged, and of those 3,000 PMVs, they were responsible for more than 20,000 cases in 2022. Again, we looked at what made this possible. One of the things we can point to is that the use of the MATS app. So I'll be speaking briefly about the MATS app in my subsequent slide. That's the mobile application for TB screening that enables these providers to be able to have some much more accuracy in their TB screening and resulting in more cases. Next slide. In my opening slides, I mentioned that we were looking at taking access to molecular diagnostics to 75% at the end of 2023. So what you see on this slide is just showing you what the picture was at the end of 2022. Up to 70% of the patients diagnosed had GeneXpert as their diagnostic test, but we still had about 10% who were diagnosed with AFB microscopy. Most of these patients who had AFB microscopy were those who came from PMVs, because PMVs still have the challenge of getting all the clients they identify with symptoms of TB to a molecular diagnostic point. So one of the measures we put in place here is to ensure that every patient who was identified with AFB microscopy still gets to have an expert test conducted to rule out reef-resistant TB. Next slide. So I spoke about the MATS previously. So this is the MATS app. The app is Android-based, and it runs on artificial intelligence, and that helps to improve the predictive capacity to identify presumptive patients. So this has really improved the efficiency of the screening done by our PMVs and largely by our providers. Yes, the coverage of this app is not yet 100% because we have issues around people owning the Android devices, which we don't provide. We have challenges of internet connectivity and data, but for the facilities and providers who have been engaged and are using the platform, it has really improved their screening efficiency, and we continue to get good results with this app. Next slide. So I just want to share one of the success stories. In Nigeria, like the national coordinator mentioned in his opening remarks, he spoke about how we still have, as a country, we are trying to ramp up childhood TB notification in Nigeria. And one of the strategies that demonstrated effectiveness was going all out in the community to do outreaches centered around improving childhood TB notification. But this success is something that we already saw from the PMVs in a state in Nigeria, Sokoto State, from about 2 to 3 years ago. What the picture you see on this slide is that of a PMV in Sokoto State, who is the only healthcare provider in his community. And he has a lot of patronage. Since we engaged him, he has been able to identify more than 2,000 cases in the last 3 years from his community. One of the things he does for childhood TB through this Global Fund support that he gets is to gather the children who have signs and symptoms of TB. He gathers them in a central location, and the state TB program provides a bus. With that bus, he's able to take these children to a designated X-ray center. All these children get chest X-rays, and a radiologist reads their X-ray results. And in last year alone, he was able to identify more than 200 children with TB, which contributed significantly to the childhood TB notification in that state. So this is one of the success stories of PPMV engagement. We know that many of these children could have gone on to become very ill and die, if not for efforts of PMVs like this. So I'm saying on this slide also that through the engagement of PMVs in TB response, we have been able to reach more than 2 million people with TB services in the last 4 years. We have also been able to see that investing in PMVs is very cost effective and shows value for money. We also see that PMVs have been able to benefit from capacity building, which many of them lack, through their partnership with the TB program. Next slide. So what are the lessons we've learned in the last couple of years working with PMVs in TB control? We've seen that the hub and spoke model is very effective. And we've also seen that PMVs require a higher frequency of technical support and supervision. It helps them develop their skills and capacity to offer other healthcare services beyond TB. And we see that we cannot build their capacity using our voluminous texts and manuals. They require something that is customized to their context. In many of the places where we work, the PMVs cannot even read English, but they can read their local languages. So they require us to provide job aids and tools that they can easily relate with. We've also seen that strategic collaboration with their regulatory bodies and umbrella organizations is very key. That's a lesson that we are learning and we are working on improving. So they have their regulatory bodies that are quite strong and their umbrella organizations. And if we can engage with them, we can get more support and collaboration. For PMVs play an important role in contact investigation and TB preventive treatment. So that's one of the goals of the TB program in the coming grant. And we've seen that if we want to effectively engage healthcare providers to take on TPT, we should bring it closer to the community where the patients are, where the people are. And PMVs play a key role in this regard. We've also seen that paper-based reporting is not effective. So I mentioned some of them are not very literate. And so when we bring our paper tools, our registers for them to fill, they find it a challenge. And some of them actually, it discourages them to continue working with us. So that's a lesson we've learned, that we need more digital technologically driven solutions to engage with this group, and very minimal paper-based reporting or documentation. We've also seen that we need to scale up access to the WHO-approved molecular diagnostic platforms like GeneXpert, TB-Lamp, and TrueNat, because if we have more of these platforms closer to where the PMVs are, we will be able to find more cases actually, especially those with rifampicin resistant or DRTB cases. But we've also importantly noticed that the financial incentives play a key role. The incentives we're talking about are not much in the context of these providers. They are not asking for so much because they don't incur operational costs like the regular hospitals. They just need something to get by. So we've seen that if we invest in performance-based incentives, financial incentives, we would get a lot more results from this group. And that's one of the lessons we have learned. And lastly, we have seen that we need to engage more providers across the country. The national coordinator reiterated that over 60% of Nigerians first access healthcare in the private sector. Largely, they go to the PMVs. So we need more PMVs to improve access to TB services for Nigerians. So these are some of the points that are put up for us to see and discuss around because of this webinar. Thank you very much.
Thank you so much, Dr. Adetiba, and very interesting presentation, and definitely a lot to discuss. I can see people are already raising their hands, but I just wanted to mention that we will keep questions, comments, so on and so forth to the end of the after everybody has finished presenting. But in the meantime, feel free to put up your questions or comments or whatever in the comment section. So number one, you don't forget, and then the rest of us can also see that as we go on. Thank you. So next,
Yes. Okay.
Yeah, sorry, Stella, please continue.
Okay. So thank you so much, Dr. Adetiba, for that wonderful presentation. We have seen some of the activities of the PPMV in TB service delivery, and we are glad to have you deliver this. So at this point, I would like to invite Emmanuel Olashore, who is going to share with us the lessons learned from Shops Plus experience. So, Mr. Emmanuel, you have 15 minutes.
Okay.
Yes.
Sorry, give me a second. I'm trying to put up your presentation.
Okay.
I'll be with you shortly.
It's all right.
All right, it's on right now. So I'll be, just let me know when you want me to change the slides. And also please, can I request that you try to keep it to 15 minutes so that we can get everything that we need to do on time and not keep people, keep all of us who are so busy from other things. So thank you. Okay, please go ahead.
Yeah, I will try to stay within the time limits. Okay, so thank you, great one. Olashore Emmanuel is my name. I currently work with the TBDR project implemented by John Snow, Incorporated in Nigeria, as the Strategic Information Advisor. And I'm going to present my experience working on the Shops Plus project. The next slide, please. So the project implemented between 2018 and 2021. So this is the outline of my presentation. I will be talking about the overview of the project and how we engage the PPMV in Lagos. I will talk about the whole process, including the result and challenges. Then I'll also be introducing the participants to the 300% policy campaign, which is a campaign that was developed in the course of my journey in the PPM world. Okay, the next slide, please. So the overview of the short slots project. The next slide. So the short slots project is a USAID funded project, and it is a flagship initiative in the private sector in Nigeria, the first of its kind. Before then, interventions have been focusing on community intervention, provider, private, public facilities interventions. The private sector has not been involved in TB service delivery to a large extent in Nigeria space. So, but the short slots project gave the opportunity to test as a proof of concept for engaging the private sector, and the goal is to increase detection and treatment through private sector approaches in Nigeria. The project is implemented in 15 states and the Federal Capital Territory with the objective to increase availability, quality, and flow of TB services and strengthening health system to foster and sustain public-private mixed models for TB care. Particularly in Lagos, the model we implemented the urban spoke model, like Dr. Adetiba talked about, the urban spoke model implemented in the short slots project. We have the clinical facilities, which are the hospitals in the center of it, and we have referral coming in from the private laboratories, the community pharmacies, and the patent medicine vendors, which is the subject of this course today. So the next slide. The next slide. The next slide. So in the engagement of the private sector in Lagos, can you go to the previous slide, please? So in the engagement of the private sector in Lagos, the short slots project adopted 3 key strategies to engage the private sector, the private patent medicine vendors. The engagement with the association management is key, like Dr. Tetibia said, is very key, because these associations have a good grip of the members of this association, who are the patent medicine vendors themselves. And another strategy is also we do outreach meetings with the PPMV association members when they have their meetings, and further introduce, having engaged with the PPMV management, association management, we also visit their meeting points to also discuss with the members and encourage them to join. Then our team member also do direct visits to the patent medicine vendors in their shop, individual patent medicine vendors in their shops, to also engage them. The central to this whole engagement, like every other engagement of the other cadres of providers on the short slots project, is inked on the intermediary organization, which was engaged to do this across the states where we implement. The next slide. So the PPM scheme in Nigeria, basically there are 4 basic schemes for PPM engagement. The public-private mix scheme. We have the first scheme where we identify and refer presumptive. This is the scheme that most PPMVs are engaged in, and all of them are engaged in. The second scheme is the identification of presumptive TB and TB diagnostic services and referral for treatment. This is another scheme which some private hospitals, labs are also engaged in. The identification of presumptive TB and treatment of diagnosed TB. This is what hospitals are engaged in. Well, we have some hospitals who have also laboratory services and who provide diagnostics services and also treatment. This fall into the scheme 4, where they identify presumptive, do diagnostics, and also do treatments. So, but for the PPMV are engaged in the scheme 1 PPM scheme in Nigeria space. Now, providing support to this PPMV to do their work in the best way. The next slide. The Shop Slots project provided various supports to the PPMVs. This support include routine supportive supervision visits, which is done by the staffs of the intermediary organization that visit these PPMVs routinely to ensure that the PPMV are screening their working clients for TB, especially those who are purchasing drugs that are related to presumptive TB signs and symptoms, the signs and symptoms of TB, like cough syrup, like malaria drugs, prolonged fever. A patient can buy malaria drug, paracetamol, and the rest. But cough syrup is one key one because cough is a cardinal, one of the cardinal signal signs and symptoms of TB. So we also engage them in network meetings through the cluster. They engage them in participation in network meetings where they mingle and they discuss with their peers to also learn better. We supported them in provider-initiated outreaches where they identify a space where they can conduct the outreach. And from that space, we provide logistics support, sample movement, provide them with sputum cups and also documents to document their efforts. Sample logistics is also provided beyond the provider initiative outreaches. The PPM facility, the PPMV, just need to send in a text message through the WhatsApp platform that was created to the network officer that provides support, which serve as the linkage coordinator at that level to link with the sputum rider or the transporter that comes to pick the sample, take it to the lab, and return the result back to the PPMV who now communicate with the client. Amidst this, we also provide incentivized TB incentives for TB case finding. These incentives is provided in the form of cash to the PPMV, and in the coming slide, you see how this incentive also have impact because the Lagos PPMV are a one different set of PPMV. The different experience we have had in PPMV engagement across Nigeria, the Lagos State PPMV deviate from some of these experience. Case finding among PPMV is not as encouraging as it is in the private hospitals, laboratories in Lagos State. The private hospitals provided the opportunity to identify the highest number, even up to 80% of the total number of TB cases identified in the PPM space in Lagos State. The next slide. So this is the results from 2018, quarter 4. Actually, the Shop Slots project started in May 2018, but the engagement with the PPMV started in October 2018. You will see the relationship between the number of presumptive examined and the number of TB cases per quarter, starting with 26 TB cases in the first quarter and growing until we had the peak at 100 TB cases before the COVID. But during the COVID in quarter 1 2020, there is a twist in the programming in TB private sector engagement. The private sector stood the gap to identify TB cases during the COVID, and they were able to enroll a lot of cases, contributing about 35% of the total TB cases notified for that quarter in Lagos State. The PPMV played a role, but the nature of the PPMVs in Lagos, they are more of businessmen than health worker, because Lagos State's peculiarity is something of note that one must put into consideration. So the PPMVs in Lagos are businessmen. They are not health workers. Some of them sell drinks and sell some drugs. Some of them hide away, sell the drugs in the night, sell drinks in the morning. The major PPMV in Ojo local government in Lagos State is a POS vendor, and he does his PPMV, and he's getting a lot of TB cases. So they are money conscious. So at a point, we looked at the cost of implementation and we changed at Q4 2020, we changed the incentive package. Rather than paying per presumptive, we now pay per cases, because the PPMV prefer, they will just send the presumptive just to get the money, and a lot of them are not really functional. In the charts below, you see that we've pulled down the number of PPMV, and that did not significantly affect the number of cases we identify. We pulled down from 488 to 259 and still be able to maintain the number of cases we are getting from the PPMV, contributing an average of 6% to the total number of TB cases. In the third chart, you see how that has improved the efficiency of case finding in reducing the number needed to test. That is the number of persons you need to test to get a TB case, from as high as 19 per test to 7 persons tested to get a TB cases. This giant slide was taken to increase the efficiency of the project and work smarter on the project. The next slide. So the challenges, like I said, I think the emphasis is that the Lagos State thing is quite different from what the experience is in the country. In the north, for example, on the same shop slot project in Kano, the PPMV are the major contributor to case finding on the shop slot project. However, in Lagos, the private hospitals are the major contributor to case finding in Lagos, because the situation that warrants that is that the PPMV are business oriented, and they are more of businessmen than healthcare provider. Also, the licensing issues is also one other major challenge that affected the PPMV, the pharmaceutical society, the government official, disturbing them, thereby making them work more in the night. And the peak of their work comes in the night. And at that time, they will prefer not to screen, but to make the money. The cultural beliefs that patients not willing to provide submit their sputum for evaluation is also one other challenge that affected that provider cadre. And also the sample logistics, which we will resolve later. The sample logistics is key to every private sector engagement, because in the Nigeria space, the TB does not pay the healthcare provider. And as such, they will refrain from any activity that will affect the image of their institution when samples delay are coming. So one thing we framed up through the use of the WhatsApp to get information on real-time basis is the sample logistics system that will get better, and also giving them a new time when the sample, if it's 2 weeks, yeah, tell them 2 weeks. Don't tell them 3 days when the sample will take 2 weeks, because that will also have an impact on the image of the organization. The patient that gets a result late for TB, we assume that is their practice. We run away and demarket their product. The next slide. So now, having said that, I deem it fit as this is a good opportunity to present the 300% policy campaign, which we as a team worked on in the later part. You know, the short slot was transitioned into the TB Loan 3 project implemented by Institute of Human Virology Nigeria. And during the implementation of this, come up with this 300% policy campaign, which is promoting private healthcare sector ownership of the TB case finding. The next slide. So the background to this 300% policy campaign is that the private healthcare provider, they provide 60% healthcare provision in Nigeria. Even when we have big hospitals that can provide service to 200 people, we have like 100 of small hospitals that provide service to 20 people or 30 people per day. And that increased the number of the share of the private sector in the healthcare market space. And also looking at the prevalence incidence rate of TB in Nigeria, 200 per 100,000. Lagos State alone have, with an estimated population of 20 million, estimated different facts everywhere, but 20 million. And we know that the contribution of the private sector to TB case finding in Lagos State is still really low at 20%, not meeting up with the 60%. This is one of the things that necessitated the development of the 300% policy. This is also backed up by global and national policies, the systematic screening for active tuberculosis principle and recommendations, which is published by WHO in 2018. And the 61st National Council on Health meeting held in Kano in 2018, where it is recommended that in population where TB prevalence, according to WHO, in population where TB prevalence is as high as 100 per 100,000 population, TB screening should be done at all healthcare facilities. And the Nigeria National Council on Health recommended that TB screening should be done in all health facilities. This is what necessitated the review of the OPD register to include the TB screening, and also encourage in the private health PPMVs and other outlets. The next slide. So the 300% policy is so simple, just the use of data to just stimulate action to identify cases. So it will ensure that no TB case visiting any private healthcare provider lives there undetected. And the first 100% is to ensure that patients visiting the facilities are screened. 100% of them, all of them. This is what the Trust Plus project aim to achieve, and they will push this to a very logical extent, and we were able to see the gains from it. And I feel that sharing this at this with this audience will also give opportunity to improve case finding in the private sector, including among the PPMV. The second 100% is to ensure that identified presumptive are all tested, all of them 100%, and the third is 100% of these TB cases are detected and linked to treatment. The next slide. So this is the document I was talking about the screening, symptomatic screening for active TB. You can check up this document with the WHO recommendation, and also the communique of this 61st Council of Health meeting is available online. Can also be annexed by the PPM providers at this level. The next slide. So the resources in the TB program have supports this 300% policy, and this is incentive for presumptive TB identification, incentive for treatment, TB treatment initiation, incentive for successful TB treatment, screening officers to support screening high volume facilities, and the rest, sample logistics, field diagnostics, and quality improvements support. These are some of the things that are available to support the implementation of this policy campaign. The next slide. I think that is all. Thank you so much. I hope I'm able to do within 15 minutes as requested. Thank you.
Thank you very much, Emmanuel. Stella, please go ahead.
Yeah, thank you very much, Emmanuel, for your wonderful presentation, sharing your lessons learned from Shop Plus activities in Lagos. So we can see the major challenges that they have in Lagos is that they are business-oriented people, and majorly is the private hospitals that are major contributors of the cases. So, and they had their licensing issues. So they work more in the nights. And so because they are business oriented, their activities is more in the night. They sell their drugs mostly at night, and probably in the daytime is their drinks and the rest of the other stuff. But even in spite of that, some of them, even the ones that are, having other businesses, they also help to get more cases for us. Then we have this cultural belief that is so strong there that sometimes you find the cases or the presumptives, they find it difficult to even produce a sputum, and sample logistics also was an issue. So we can see that, yes, even in spite of all these challenges, they were able to, provide, implement incentive, this incentive-based for PPMV, for better service delivery. They also had to do this hub and spoke model where they had to engage the association of the PPMVs. They also had to engage the individual PPMVs themselves, and outreaches are also conducted with the association members. So that is so wonderful. Even in spite of the challenges, all these things were done. The one that is also very interesting here is the 300% policy campaign, where every individual that comes or visits a private hospital must be, the individual must be attended to. And after being attended to, must have access to diagnosis. And the other 100% must, if the person is a patient or is diagnosed of TB, must be put on treatment. So we are very glad to have all this from your presentation. Thank you so much. So we now have to listen to the perspective from a patent or patent medicine vendor who is licensed, who is also licensed, Ojeleke Folashade. Ma, you have 10 minutes to share your experiences with us. Thank you very much.
Thank you. Before you start, Folashade, please, can I request that you also be brief so that we save time? Thank you. So we're looking forward to hearing your experiences. Please go ahead.
Good afternoon, everyone. My name is Folashade Ojeleke, the MD of Damna PPMV, under Alimosho, Lagos State. My shop is at number 4 Gani Street, Iyanopaja. I joined the TB program in 2018, September 24, under the Shop Plus, which was led by Lord Jing Gates, which they coordinated me how to spell. They teach me how to train my people, how to train the client, how to collect the sample, how to call the rider in case when I have a presumptive case, so that they can go and do the test and bring the result for me. And if there is a case, then I can refer my client to as a clinical facility. So when we look at it, more so, but now I'm under the TB loan that was funded by that IO was funded by USAID in Nigeria. So also, I would like to share my success story with every one of us. But before I proceed, I can be able to remember that during that time, Dr. Flora and Dr. Lindy, they used to teach us how to screen our clients, because by that I was thinking that how am I going to do it? But Dr. Lindy tried to come to our level as a PPM vet to make sure that we can be able to understand how to screen. So that's how I can be able to have one of the success stories. I can be able to say that during my screening, since I've done the TB, I can be able to say that I may have up to about 36 cases that are already be treated. And if you look at the presumptives, I have about 432 plus or more than that the people that have been already screened that collected the sample. But in there, I can be able to say that I can still have up to 36 cases that are finded in my area. I would like to share one of my success story that I can be. Since that time, I think that the TB program, I need to take it as a more important in my community. There was a time when we are doing the outreach. So I was telling everybody, please produce samples. This is a communicable disease. So let us treat ourselves. This is something that is going on. So there's one of my apprentices that been in my shocked. So when we are talking, she was trying to, I still add that he's losing weight. I said, "Ah, it's still part of our screening that they taught us that time in September." So I just told her that, can you do examples that you two can produce, although you are not couple. But to my surprise, when she produced the sample, I called the rider to come and pick it. When they picked the sample, they can be able to diagnose that she have the case was positive. So I was shocked. Supposing that I was not under this TB, I will not know that something like this is occurring in my facility. So I tried to call my network officer, and she also mentor me the way I can be able to do the cancer more forward, and we refer to the clinical facility that she can take her treatment. And she take the treatment. Later, and I tried to do the contract tracing in their house. To my surprise, I can be able to get about 2 of her parents, our elder sister and another person that already have a TB. When we did the test proved positives. Even there is a child that used to play with me, that used to play with she in my facility. That child also contaminated this thing. So, but to God be the glory, I tried to call them one by one. I canceled them, and they thank God the TB they have already taught us the way we can do. If the children cannot be able to produce the sputum, we can also take the stooling or do the chest X-ray. But by the God grace, we take this. I collected the stool. So for the sample, I called the rider, and the rider take it, and the result come out with the positives. We also so I call my network officer. There is a time that we don't have the dog of that age of that child down. My network officer, they will immediately call the TBLS to help us to collect the drugs so that we can immediately, the following day, early in the morning, they have bring the drugs to the facility that they are using. I'm using about 3 clinical facilities in my area. I'm using Leeway, Medisol, Better, anywhere that can be able to confident for my clients so that they can use. And they all treated and they are all okay. In fact, it really brings a lot of customers to my shop because they respect it that what I'm doing in my shop, they respect that what I'm doing, everything is okay. So when we also, although there are most of challenges that we have, that some of the clients, when we give them cup to produce their sample, some may not return the cups, and some they may not even they may not even bring the produce the correct sample. They may just produce saliva. In fact, that's why there was a case that since over 7 months, I've been trying for that man to produce a sample. The man cannot be able to produce the correct one, and the sample was still proving negative. There was a day he now just come and tell me that he used to have a night sweat. And I said, okay, Oga, I don't know, but you used to do this test. It's always proved negative. Can you produce another one? From the last one that he produced, that he can be able to get that, the man was positive TB, and he was treated. Now, the man was still patronize me and buying market more for me. So, but some patients, they'll be on the drugs. One of another challenge that we have on this TB, that because I need to be a treatment supporter for them. Some of them, if you don't call them, they may not take that drug. Some of them, they break on the road, say, no, I don't want to take this drug again, no, because it's too plenty. For 6 months, I cannot take it. But it's my duty to call them one in one. And then sometimes, some of them will not give the correct address for us. Even some of them will not give the attention to record their name. They say, no, I don't have this thing, no. But I used to talk to them in a normal way. Some will call them officially so that they are not going to be exposed, because some of them believe that when we are saying this thing, people will be hearing it outside. And then to my other PPMV, because since I've done this thing, that I've tasted it, I have seen it, because when I want to join before, I think that this thing cannot fetch me anything. I'm thinking that how am I going to succeed on this thing? How am I going to see my finance? Instead of me to sell my market, pack up to get my money. But when I now see what is going on there, I also introduced to about some of my colleagues. I can see that I have about 7 people that have already introduced to this TB program, and they are doing well. Even some of them are bringing presumptives that they are calling. I know, even I have one that he also gets 1 case from his own. From that case, you also get another one that have a children that having that case, that people are saying that now offer before we know. But to the God of the glory, the TB people, they are very, very wonderful. They did a wonderful thing in my area, including all my network of staff. For the meeting, they are calling us out to school. Even sometimes, if I want to relent, they will still call us. Let us do this. This is how you can do it. But the only challenge that I see that is affecting most of us that being a PPMV, that number one, Dr. Emmanuel have said it on the last one. Secondly, when we look about it, some of us will need a finance incentives because say everything, money is the very most important is there. So if TB can also be helping us in a little month, I think this thing can jingle up because most of them, if you tell them they should join this program, they say, are they going to give me money? But although money is not the first thing, because this thing is still going to bring a lot of benefit to our facility. So if they can add money, nose mask, everything. Although TB, they have already tried, they invite us to the association, they have already done that. In fact, they are doing well on those things to call us for the meeting. But if they can also to help us for the finance, I believe most of our people will join this program because it's a wonderful program that I can never forget in my community. Even from my community, they are really appreciate it. Thank you very much. Hello?
Thank you very much for sharing your story. That was very interesting, and there are many fantastic things to pick out of what you're saying. So I will I'll open the floor now to the anybody who has joined the call who wants to ask any questions, make any comments, has any specifics that they want to add, want to share their own experiences as a PPMV, as an implementer, as someone in the national, whatever it is, the floor is open. So please feel free to start to raise your hand so that we can have an organized discussion. And so while we wait for people to come up with their questions, I just wanted to share some of the questions that have already been written in the chats. So this question is for Dr. Adetiba and is from Dr. Stephen John. Dr. Stephen, if you're here and you can unmute, you can take over asking your questions directly. But in the meantime, I think I can just maybe read out what you've written. Thank you for the nice presentation. Apologies, I'm not able to operate my Zoom well. How much incentive is given to PPMV? From the presentation, the PMVs identify and refer presumptive TB cases to diagnostic centers. Any data on losses along the way? Let's maybe take one at a time. Sorry, there's noise in the background. If we can just mute if you're not talking.
Okay, Aji. Thank you very much, Dr. Stephen, for your questions. So for the PMVs, we have what we call our cough to cure document that speaks to how much each class of our provider is paid for as an incentive. So we grouped these payments into incentives and enablers. So most of the activities we actually have, they get enabled to find cases. So those are enablers. So if I have to go through them all, it's quite a number, but I'll start for identifying a presumptive. So screening and identifying a presumptive, they get paid about 250 Naira for screening and identifying a presumptive, but they don't just get paid for every presumptive. So we capped it at 7 presumptives to 1 case so that we can ensure that there is no abuse of that system. So if you do quality screening, if you use your MATS app, that's why the issue of MATS app comes up, there is a high chance that anytime you identify a presumptive, it's a high chance that it will be a case. So for that, they get 250 Naira. And for each confirmed case, for each positive case, they get 2,000 Naira. So those are the 2 major incentives for case finding. For the samples to be moved from your PMV to the diagnostic point, the linkage coordinator does that. So you don't have to spend money in picking up your samples. Another good thing that we have brought on board is that to get your money on the go, that's immediately your services are provided or shortly thereafter, the MATS app now has a payment module that does calculate how much. So you have a wallet, and everything you earn while you are working, while you are doing the TB work, is going into your wallet, which can directly go to your account. So these are things that we've come up with to make the process better and efficient. He asked about the losses. So if you looked at my slide, I had one slide showing the cascade and that tracks losses if we had in the system. If you notice that where we had a few losses was at the point where the patient is identified, but he's not yet on treatment, he's not placed on treatment right away. So out of 56,800 cases, the losses we had was about 800. And these are the kind of situations where Mrs. Ojeleke just mentioned, where the patient gives you a wrong address and you cannot track them, you can't find them. So one of the jobs of our linkage coordinators is to try and find in that environment where the patient is and get them to start treatment. I think I've addressed those two questions you asked, Aji.
All right, thank you. He has more questions. So I was wondering if Dr. Stephen can take on the questions directly. I think some of them are also comments. Are you able to unmute?
Okay, I've seen question 3 and 4.
Okay, so it looks like he's not able to unmute. So if you could just go ahead and respond to his questions.
Yes, so he's saying that our model appears to have a lot of tasks for the PMVs to undertake. And he was citing their experience with TB Reach in Adamawa and Yobe states. So like I said, we have seen that in some of the instances, and this is from our work in the field, and also now learning from the regulatory and umbrella bodies, that the PMVs have a tiered accreditation structure, that there are PMVs who are capacitated to do much more than just identify and refer, which is primarily what we demand from our PMVs. They just identify clients who have presumptive TB and refer. They don't have anything to do with diagnostics or treating. The only other task we can add on is to supervise treatment, which Mrs. Ojeleke also alluded to, that she follows up her patients with phone calls to see that they are on treatment and they are doing fine. So those 3 tasks are not in any way such of a burden. But for the highly skilled PMVs, what we are seeing is that those people can actually put patients on treatment because they are trained health workers and they can do that. So that tiered accreditation structure is something that we've seen to be effective. Regarding busing children to go and do their x-rays. So in Sokoto State, they don't have the good fortune of getting these portable digital x-rays that the TB program has in a few states. That is just recently being addressed by the National TB program. So each state in the country is going to have these portable digital x-rays in the coming months. But for now, that is not available. And Sokoto State is a largely rural state. So you only have x-ray facilities at the city center. So everywhere that is outside the city center, you must bring the patients to the city. And this journey takes 2 to 3 hours. 2 to 3 hours. We know it is not ideal to move children that long, but in considering the circumstances, it's better to have that x-ray and save the child's life. And the parents don't have to pay for these services. So it's all free than to leave them without an x-ray because of the inconvenience. So we've weighed all those options, and that's why busing them was the best alternative in that instance. Thank you.
Okay, thank you very much. I don't know if Musbayo Tijani is still on the call. You had a few questions. One of your questions was, has there been any documented experience in the use of PPMVs as pseudo hub in the management of TB patients, and how feasible has it been? So if you're here, please, can you just share more? I don't completely understand the question of what a pseudo hub would look like. So if you could, that would be really helpful. In the meantime, Chioma Adetuyi has made a suggestion. I don't know if something that has been thought about by the program. So
Hello.
Hello.
Hello, good afternoon.
Good afternoon.
This is Tijani.
All right, welcome. Thanks for joining us. Please go ahead with your question about the pseudo hub.
Yes, first of all, so I appreciate all the presenters for the wonderful presentation. It has been so interesting and educative. So how do I mean by pseudo hub? Is that like example showing in the Sokoto state where the PMVs is the only healthcare facility available in that community, and they have to bus in the children to the city for chest X-ray. If we now confirm a TB case, so it may become very difficult to move the children and register them in the city for treatment. So in a situation where we have to now engage the PMVs to stand in as a form of treatment supporter instead of children or parents traveling now. So the program will be moving the drug down to the PMVs. So we'll be dispersing doing the dots for the patients to have their treatments. And when it's time for the follow-up testing, we'll also collect sample. In such a case, although the PMVs is ordinarily a spoke, but in that capacity is functioning as a hub. So, and that's what I mean by pseudo hub, because it's not really a healthcare, an hospital where it's not a really dot center. So I don't know whether that has been practicalized in any of those places where these interventions where review has taken place, and what is their experiences, particularly in the northern part of the country. Thank you. Over.
Yes, Mr. Tijani, you are spot on, actually. So this is actually what obtains in these instances where the PMVs are the only healthcare providers in their locality. So the local government TB supervisor, when these patients are diagnosed, takes over at that point, and he looks at, first of all, he has to register those TB patients in a hub facility, that's in a DOT clinic. So once they are registered there, the second question is the logistics of getting the patients to take their treatment for the duration of TB treatment. So what they do in this instance is that the local government TB supervisor brings the medicines for each patient, and the hub facility, the spoke, that PMV now becomes a pseudo hub, like you have stated. So the medicines are kept with him so that those patients, because they are mostly poor and rural, don't have to keep on traveling to the city to access their medicines. So this person starts as the treatment supporter, giving them their medicines and ensuring that they follow through. The TBLS comes there once a month and does the monitoring, check whether the patient's medicines are being taken as prescribed, checks their weight, and does the other documentation. So that's the pseudo hub model. And that's exactly what obtains in these parts of the country where we don't have a hub facility or a DOT clinic. Thank you.
Thank you very much. So can we go to Tad Daniel? So we're unmuting you, allowing you to be able to speak. So your question was, what mechanisms do you use in the engagement of PPMVs? Do you, basically talking about MOUs, what obtains around MOUs? And in communities where some PPMVs do not have Android phone, how do you avoid using paper? Because I think it was mentioned that that it is usually a challenge filling paper-based phones. So if they don't have Android, then what do you do in those cases? And then lastly, do PPMV support with treatment within communities? I think that has already been responded to. I think Dr. Tetiba talked about the different schemes. So some do, some don't. But Dr. Tetiba, I'll let you respond to this.
Okay, thank you, Aji and Daniel, I think, for the question. So how do we get the providers to documentation where there is no Android device? In fact, largely, most of our documentation is still paper-based. I mentioned that as one of the lessons we've learned. The TB program in Nigeria has not yet gone fully electronic. And so most of our reporting recording is still on paper-based tools. So how do we support PPMVs who do not maybe know how to write that much, or who don't have the time? And Mrs. Ojeleke said, I just want to make my money sharp. So they don't have the time to be filling all those forms. So what do? We have provided referral forms that are, because their tasks are not much, so very brief forms where you just have the names and whether this person is symptomatic or not. So that's easy to track. Secondly, the linkage coordinator assists those who are not very literate in making sure those documents are properly updated. Thirdly, that Android device where they have the Maths app, once you do not have one, one of the things that we encourage is that the funder provided a limited number of Android phones. So we make that available for those kinds of people, and they are able to update. And the idea is that once they have seen how useful and important it is, at the end, they also want to get their own Android device. And because this from the funder is not a gift, it's just to enable you do your work. And so we can give it to another provider who needs it. So those are some of the ways we've tried to address it. But largely, we are still heavy on paper-based tools, which is something the country needs to look into going forward. Your second question, I missed it.
I think his second question, did you respond to the question about MOUs?
Yes, so the MOUs, what we have in the MOUs after when we are engaged a provider is to list your roles. So what do we expect from you? That's why we let them know clearly what it entails in the TB cascade. Where do they come in? So that's clearly stated in the MOU. The second aspect is what is in it for you. So what are the incentives? What are the enablers? We state it clearly in the MOUs. And this is something that, like I shared in my presentation, we have done with over 12,000 providers in the last 4 to 5 years.
All right, thank you so much. So we have a few hands up that I would, the next person is, okay, Bukola. I don't know if she's still here, Bukola or Lani. Her hand was lifted up. So can you unmute and speak and just say what you wanted to say?
All right, thank you. Good afternoon. Wonderful presentation from my colleagues, Dr. Adetiba and Emmanuel. Just some few points that I noted down while I was waiting for this webinar, as looking forward to how to improve case finding, participation of the PPMVs and improve case finding and notification from them. I just want to pay particular attention to some challenges and then, categorize, clearly look at them. Of concern among the challenges listed is the incentive package, which Dr. Adetiba talked about. there have been a lot of requests from them, the PPMVs, saying that the amount should be reviewed, And I feel that reviewing it, well, we all understand the situation in the country, and I'm just imagining for how long are we going to review? No amount of money can actually be enough to cater for this incentive package. Rather, I'm looking at a way to get the PMVs. We are looking at a way to get the PMVs understand their role and appreciate their role more in finding the missing TB cases and more service to humanity than the emphasis on the package, which I think, to the best of my knowledge, I've been hearing that they want it to be reviewed up, and reviewing it up may also not be sustainable. So I think it's something that we need to look around. Rather, in one of the states supported TB Loan 3, what I got is timely payment of incentives that actually was one of the factors responsible for the successes recorded. So I think one learning that I got is how to make sure that incentive is paid on time and is regular. I think that will serve as a source of motivation to them. Then for Emmanuel that spoke about Lagos, the business-like model in Lagos, I just want to throw this question back as I'm just racking my head to see what we can do differently in the engagement. I know that in one of his slides, he mentioned previous efforts engaging association heads, but of recent, I've noticed that I don't know how much that has helped in recent times, because the feeler is that even the association heads have expectations from the program, which the program cannot meet up with before engaging the PMVs itself. So I like that this we shed more light on this and know the way forward on this. Then on we also should pay attention to issue of stigma and other issues like licensing, like they mentioned, and how we are going to tackle this, how we are going to engage government, and how to ensure that while we are trying to engage as many as possible, ethical procedures and ethical issues are taking notes of. Thank you, and over from my side.
Thank you very much. So I think you raised some very important points. I think one thing that stuck out for me really is the motivation issue that you mentioned. As you said, there's only so much motivation, there's only so much money that it's not a profit-driven kind of initiative. There's only so much money that can be put into this, and it will never really be enough. So I think we need to explore with the PPMVs that are highly motivated, because you have a few of them who are highly motivated. Madam Folashade is one of them. And you see them really taking this thing on personally. You see them really engaged, not just PPMV, but private sector in general, some labs, some, you see that they take this thing on beyond just the money. So maybe we can explore why, like just ask that question quite broadly. What is it that keeps you going, despite the fact that the money might not be overly sufficient? Of course, incentives is definitely a big part of it, but I think just exploring what it is that keeps them going is helpful to be able to expand it to other people. I think Madam Folade had also mentioned the issue of recognition even within her community. Now she's, she has this sort of recognition. They know her for TB. She's a respected member of her community. That guy in Sokoto must be very respected if he's the only health provider. And then now he has that endorsement, from a national body, from government, so those kinds of things. I think if we can sell it better to those who are not necessarily interested or not as motivated, it might be helpful to sort of bridge the gap. I think there are many incentives that are non-monetary, and I think we need to explore that more. So we kind of are quite a bit out of time. I want to give the floor to Adakole Oko, who also has his hands up, and then maybe we can start trying to close. So please go ahead.
All right. Thank you very much, all the presenters and those who have contributed. Just very briefly, two things. One, this PPM program or strategy needs to be completely owned by the various state programs. Even though it's PPM, but all the PPM implementations are still under the overall tutelage of the respective state TB programs. And from our experience, we notice that sometimes there is a disconnect, between the PPM structure and the state programs, in the sense that the TBLS, a lot of them focus more on the public facilities when they do their oversight. So there is the need, even though the state programs have owned the PPM, there is need for more ownership. There shouldn't be that dichotomy that, okay, this is the private sector, our focus is more on the public sector, which more often than not is the case, with the TBLS, who are the custodian at the local government level. So one of the things we've done in our organization is to ensure that we carry them along in oversight in the various states that we implement at the state level. So that ownership, by the state program is key, because eventually the entire TB data generated in the state program also belongs to the state, from where the data is now transmitted to the national program. So we should push for more ownership. Then the other factor is there is need for domestic resource mobilization. We can't run away from it. This is an incentive-based program. And a lot of those who are implementing the PPMVs, they are not running charities, so, and considering the economic situation of the country. So in as much as we try to ensure that they are motivated to contribute their own quota to TB case notification, they are set up for business. So, and this is one of the things they do to augment, their sustenance. And so there is need for domestic resource mobilization, because we are dependent on donors. So I'm afraid in the very long term, if these donors pull away, how do we sustain this? So those are the few points that I want to make. Thank you very much, and over for now.
Okay, thank you so much. That's very very important point you raised. I just want to mention a comment that Chioma Adetuyi has put in the comment section. She suggested liaising, that's the program, basically liaising with pharmaceutical companies that manufacture cough syrup, and have them add some sort of messaging to ask the people who buy from them that if you are still coughing after 2 weeks, then maybe you need to test for TB. I think it's a good idea. That's still private sector, and it's something that we can potentially leverage. So definitely worth thinking about. So now I want us to close. Before that, can I give like 1 minute to each of the panelists to just say any final last words? So we'll do it the same way that we did the presentation. So we'll start with Dr. Adetiba, then Emmanuel, and then finally Madam Folashade.
Thank you, Aji, and thank you everyone for your attention. We've already said so much, but I would just say that Nigeria, we are at a very critical phase of our TB control efforts. And at this phase, we need all hands on deck. We need all providers involved and engaged. And we should focus on every sector of our healthcare service provider spectrum that can contribute to increasing our TB case finding and improving our TB prevention strategies. And lastly, we really need the buy-in of all partners, so not just government. We've talked about private sector, in industry. We need the collaboration of those partners. And lastly, we need to be learning from each other. So that's why the PPM Learning Network is a good platform where we can share experiences, so that we don't just sit and work in silos. We need to learn from each other. And in that way, I know that we can really end TB before 2030. Thank you.
Thank you. Emmanuel, do you have any last words?
Okay, yes, thank you so much, Azzy. I think um, Dr. Temitope had just said a lot. Aditiba has said a lot. But I'll just quickly want to add in my closing remark that the engagement of PPMV, you cannot give them enough money. And what we should be looking at is engaging them so that they are owning the program. Engaging the leaders does not necessarily mean engaging the PPMV. We must have direct engagement with the PPMV that will do the work, not the PPM, not the leadership of the associations. And also, PPMV have a great potential in reaching out and identifying the missing TB cases. This opportunity should be annexed the more. And I hope that this, like Dr. Adetibat said, this opportunity for us to cross-fertilize our ideas within them is very important and should be encouraged at all levels. Thank you so much.
All right, thank you so much. Madam Folashade, do you have any last words for us?
Okay, thank you very much, ma'am. Thank you for allowing me to be part of this group today. So the only word that I have that I would like that you should also encourage the other PPMV more, so that they can also motivate from what we PPMV that have already been under the program, so that they can join us. And also, I also seize this opportunity to talk to other PPMV that they should also try to emanate out of what I did, because if you are doing it, it's also improve our facility. It's also create more profit to our business, so that people can also recognize us more. So I'm using this as an opportunity to tell all that people, PPMV people, that they should also do like that in their community area. Thanks very much.
All right, thank you so much, Madam Folashade. Personally, I don't know about anybody else, but I've learned so much on this call, and I'm also very excited. I feel like there's a lot of good news. First of all, that PPMVs is definitely a pathway that we need to be exploiting as much as possible. Because you really do, when it comes to TV, you really need to go to the people. You can't expect the people to come to you. And where are the people going? They're going to PPMVs. And so if we are not able to engage them properly, then we're never really going to be able to bridge the gap when it comes to our case finding in this country. So it's an exciting opportunity. It's also exciting to see the numbers, to show that it's actually not in vain. It's actually showing real progress over a short period of time. So how much more can we potentially see if we continue to go along this path? There are lots of lessons that we have learned here. The time, I don't think is enough to really dig deep into all these issues, because there are just, there are just so many things to talk about. So please, let's not let this conversation end here. This is why we have a platform and we have an online network, and we can continue to have this discussion. We'll share the presentations, we will share the notes, and we'll pull out the main ideas and the main lessons learned and the main suggestions that have come out of this call, and share it with everyone. And we also hope that you would get on the platform and continue the discussion. If you have any questions that you feel haven't been answered, or if you feel like there's more you want to explore, feel free to start a discussion on the platform. Feel free to start a discussion on maybe any of the WhatsApp groups, and we'll take it further. We also want to hear your feedback on how this webinar went, what you would like to see for the next webinar, the kinds of topics you want us to discuss, what went well, what didn't go well, how we can do it better, so that we can do more learning and leverage this platform for the betterment of the entire program. So thank you so much all for joining. Thank you very, very much to all the presenters. Thank you, Dr. Adetiba. I know you're really busy, so thank you for carving out time to be with us. You pulled out many amazing insights. And it was definitely very interesting to hear. Thank you, Emmanuel. It was also really interesting to see the work you are doing. It's also interesting to see the differences from state to state. You're sharing certain things that sort of contradict what Dr. Adetiba is saying, because he's talking from a different point of view. But from Lagos, you have a different issue. So it's nice to see, that broad overview of what's happening and how it differs from state to state. It's also nice to see the similarities as well. So SHOPS Plus, TB Loan, IHVN, the Global Fund grant, we see a lot of similarities. So we know for sure that this is definitely what is going on. And the solutions that are coming out from each of these programs are definitely helpful for all of us to hear. We need to find a way of managing knowledge well, so that even if a program ends, if a SHOPS Plus ends, the lessons learned from SHOP Plus, the things that they've seen, the strategies that they have used that worked should belong to the program. It shouldn't belong to SHOP Plus. It shouldn't belong to individuals. It should belong to the national TB program. It should be used for the benefits of the national TB program and for the Nigerians who have TB. So it's nice to have such a platform where we can discuss this and hopefully document some of these experiences, and hopefully have it, somewhere where we can always go back and say, okay, this is what was done and this is how we can take it forward. So thank you all so much for joining as well, for all those of you who have joined, for those who have shared their questions, those who have given their comments. They're all very, very appreciated, and they definitely add to the flavor of the conversation. As I said, we will take this, we'll make sure that we consolidate all this information and share it back with you, and then feel free to also interact with us on this. I'll just give Stella. So that's all from me. Thank you all very much. I'll leave it to Stella to just close for us.
All right, thank you very much, Azzy. Yeah, it's been a wonderful experience, and I believe we have all gained a lot from this webinar. We have looked at the PPMV activities in the TB service delivery. We've seen that, yes, PPMVs are the major drivers in the 21 states Global Fund is sponsoring, and the country is not yet saturated. Only 21 states are on the Global Fund project. Then we have also seen the schemes. The Emmanuel shared the 4 schemes that they put together during the SHOP Plus project. Then the 300% policy campaign, which they have also put together. Despite all the challenges we have in Lagos, they were able to pull through. Then we thank Fola Shade for the experience she shared with us. You can see how being observant could yield cases, somebody staying with her and finally was diagnosed of TB. And we can also see how contact tracing is able to also go a long way to get more cases for us. So all these are the things we should think about and study the area we are, so that we'll have to, the location we are, to know what works best, because it's not one cap that fits all. So what works best for us, we should try and implement it and see how far it goes. So moving forward, we could tweak some of the strategies for better results. So on behalf of the National Coordinator, NTBLCP, the entire NTBLCP team, TBPPM Learning Network, we say thank you. And we thank you for taking our time to listen and for your wonderful contributions to this webinar. Thank you very much and have a great day. Aji, you still have? Okay.
All right, no, nothing else. We're done. So thank you all.
Okay.
I think we can.
Thank you, everyone.
Thank you so much. We're really, really grateful.
Yes.
All right.